Recording. Okay. So it's the same slide, and as we have discussed in that epithelium one, we have three compartments: the epithelial, the Mullerian surface Mullerian epithelium, the germ cells, and sex cord stromal one. And we have all the tumor arising from all different areas. So we have discussed about the surface Mullerian epithelium. Now we will be discussing germ cells and sex cord stromal one. This picture is also, you know about it, and we have done this part, the epithelium. Now we'll discuss the germ cell and stromal, and in the last, the metastatic one. You know that the frequency is 15 to 20% in germ cell, and sex cord is only 5 to 10%. Malignancy, only 3 to 5 in germ cells and 2 to 3 in stromal one. The age in germ cell is from 0 to 25, means it starts from the very beginning, like endodermal sinus tumor. The baby can have this tumor even a few months old. And choriocarcinoma, usually you see in a later stage. Then sex cord stromal, we have fibroma, granulosa, theca cell tumor, or Sartori Leydig cell tumor. Then metastatic tumor, as the name says, metastasis can come from anywhere from the body, mostly from GI tract and sometimes from the breast. You know about this one, we have done this thing. Yes, now we'll start with the sex cord stromal tumor. The name you know about it, granulosa cell tumor, fibroma, fibrothecoma. Usually, fibroma less commonly seen in individuals.
Okay, this is the first lecture.
Yeah, it's a continuation to that.
I thought it was.
No, no, it's not now. But it's the same slide which we have discussed. That's why I have started, so that the people will come. So this thing is common for you. So it's a granular cell, theca cell tumor, granular, the fibrothecoma usually comes in a combination. Sartori Leydig, both tumors comes together. And then we have got sex cord tumor with annular tubules, and gynecoblastoma, and steroid lipid cell tumor. So we'll not discuss these typical tumor which are small, but we'll take 2 or 3 from there. Germ cell tumor, teratoma is the most common one, very common, and 96% they are benign, 4% they are malignant. So if they are malignant, they are called immature, right? And benign, which is mature, which is solid, or cystic. Cystic we call dermoid cyst, or monodermal, since you have some specific type, which we will discuss later on. Then we have dysgerminoma, yolk sac tumor, or mixed cell. Then we have malignant cell of no other otherwise specified. Then metastatic tumor. And we have discussed about this slide before, so I'm not wasting my time here.
Okay, this is the.
Okay. So what is actually the first 3 slides are the same. So it is common. And let's skip this one.
Oh.
Okay, so the first few slides were actually the same one. Now coming to the germ cells, they constitute 15 to 20% of all ovarian tumors. Most are benign cystic teratomas, found principally in children and a young adult, have a higher incidence of malignant behavior and pose problem in histological diagnosis in arthropy. And they bear a resemblance, similarity to the germ cell in the male testis. So in a similar manner. For example, in testis we have seminoma, in ovaries we have disgerminoma. So they are counterpart of both of the tumor. So this is a chart which we say neoplastic transformation of the germ cells if it is mature or embryonal type in a primitive. Mature, benign and malignant. Benign we have mature cystic teratoma and struma ovari and struma carcinoid. Then we have malignant one, squamous cell carcinoma, carcinoid and thyroid carcinoma. Embryonal one, we have undifferentiated one that is dysgerminoma. The counterpart is seminoma in ovary. Trophoblastic is choriocarcinoma. Even we see choriocarcinoma in testis. Primitive embryonal carcinoma, again, both testis and ovary have this. Somatic immature teratoma, and then embryonic, extra embryonic one is yolk sac tumor. Again, we see all of these tumor in testis. So if you open the ovarian tumor, germ cell and the testicular tumor is all the same. Now coming to teratoma, divide into three categories, that is immature, mature, immature and monodermal. Mature is benign, immature is malignant, and the monoderm has a specialized cell in it. So the benign teratoma, most benign teratoma are cystic. That's why they are called dermoid cyst. The cystic teratoma usually found in young women during the active reproductive years. The bilaterality is 10 to 15% in these cases. Characteristically, they have unilocular cyst containing hair and cheese sebaceous material. So, cyst, if you cut it, you see serous fluid, water or sebaceous fluid, and inside you see water, teats, or sebaceous material. On second, the reveals a thin walled lined by thin grayish white wrinkled epidermis. From this epidermis, hair shaft frequently protrude within the wall, and it is common to find tooth structure in that cyst. So that is a diagnostic feature. If you see hairs, tooth teeth, or you can even see cartilage bone in that one also. Histologically, the cyst wall is composed of stratified squamous epithelium because it is the lining epithelium of the skin with underlying sebaceous gland, hair shaft, and other skin adnexal structure. The most cases, the other germ layer structures are also identified like cartilage, bone, thyroid tissue, and neural tissue. About 1% of the dermoid may undergo malignant transformation, and that turns out to be thyroid carcinoma, melanoma, but most commonly squamous cell carcinoma. Now, this is how it looks like. So, if you see, probably we cannot see it clearly, but these are hair shaft, right? Hair shaft is evident. These are sebaceous secretions. These are teeth. 1, 2, 3, right? So, sometimes it is filled with clear water. So when you cut it, water will go out and it looks like a sebaceous secretion here. Now microscopically, if you see, this is stratified squamous epithelium, lining of the skin. These are sebum, or sebaceous material, which is secreted. This is adnexal gland. This is hair follicle, 1, 2, 3, and some inflammatory cells. And it is not obvious here, but you can see bone and cartilage in some of the dermoid cyst. Okay. Monoderm or specialized teratoma, as the name says, some specific specialized area. Most common are struma ovari and struma carcinoid. Two, carcinoid and ovari. They are always unilateral, although contralateral teratoma may be present. Struma ovari is composed entirely of mature thyroid tissue. Now, this is very important. For example, if a patient whose thyroid is normal, but still his T3, her T3, T4 levels are high, then kindly look for the ovarian tumor. Because these struma ovari, which is a thyroid tissue, they secrete thyroid glands, thyroid hormone, and These hormones can raise T3, T4 level, and sometimes it is some puzzling effect that from where this is coming, and if you monitor it carefully, it looks like to be stroma ovarian, and it can cause hyperthyroidism. The stroma carcinoid or ovarian carcinoid, which presumably arise from the intestinal epithelium in a teratoma, may also be functional, particularly if it is more than 7 millimeters. What is the best area to see carcinoid tumor in a body?
Lower one third of.
Okay, you're right. Sigmoid colon or and you're forgetting the most important one, appendix. So whenever, remember, as a pathologist, if you get appendix, you see it very carefully and you cut it like this, half, and then more sections, because it is usually been seen in the tip of the appendix. And whatever carcinoid, the morphological feature is same. Now, the important thing is they start producing 5-hydroxytryptamine or serotonin, and they cause carcinoid syndrome, right? A primary ovarian carcinoid can be distinguished from the metastatic intestinal carcinoid and is virtually always bilateral. Now, this is the same thing because the ovarian monodermal tumor is unilateral. But if you see bilateral, what you will think that the tumor is a secondary one coming from somewhere else, probably from intestine, from appendix, or elsewhere. Even rarely is a stromal carcinoid, a combination of stroma ovari and carcinoid is in a same ovary. So both of them can be together. Only 2% of carcinoid metastasize. Only 2% remain, otherwise they remain in the ovary. And you take the ovary out, patient will be okay. This is how it looks like. This one is stroma ovari, in which a well-formed thyroid follicles are been formed. And inside, this is called coli. And as doctor, what you will say? Colloid, anybody can say, but the doctor will say thyroglobulin, okay? And this thyroglobulin will form T3, T4, right? And we know, we have discussed this thing earlier. This is carcinoid. And you see, these are groups of cells, groups and nest of cells. And you see how much monotony of these cells, nuclei are. And they say that in the nuclei, you can see salt and pepper appearance. Salt and pepper. What is salt? No, salt. What is pepper? The black pepper, which you put on the egg. So it's salt and pepper appearance, or you can see a small dots in nuclei. Monotony. So this is a typical of carcinoid. Immature malignant teratomas. The mean age is 18. The component tissue resemble embryonal or immature fetal tissue. They have a solid structure with the area of necrosis and hemorrhage. Hair, sebaceous material, cartilage, bone, and calcification may also be present, even in immature one. Microscopically, varying amount of immature neuroepithelium. This is a diagnostic. Immature neuroepithelium will be seen. Again, immature cartilage, bone, muscle, and other structures, but they will be immature. And important is the histological grading from 1 to 3. Now, it depends on the neuroepithelium. For example, if it is only less than 10%, grade 1. If it is 10 to 50%, it is grade 2. And if it is more than 50%, it is grade 3. Immature teratoma grow rapidly, frequently penetrate the capsule, and spread either locally or distantly. Stage 1 tumor have a particularly those with the low grade in a grade 1 histology, they have an excellent prognosis. And if it is still confined to the ovary. Higher grade tumor confined to the ovary are generally treated with prophylated chemotherapy. Most occurrence develop in the first 2 years. Now, this is how it looks like. So if you see this structure, this one, this is whole neuroepithelium. And it looks like it's neuroepithelium and it occupies more than 50% of the ovary. Now, if you see histologically, this is all neuroepithelium. See, this is all neuroepithelium. And if you compare these two areas, it is more than 50%. So we are dealing with which grade? Grade 3. Okay. So the grading of the immature teratoma is related to the amount of neuroepithelium. Clear? Dysgerminoma. The ovarian counterpart of seminoma. Seminoma is in the testis, dysgerminoma in the ovary. Account for about 2% of all ovarian tumor. They may occur in childhood. About 75% occur in second and third decade of life. Usually unilateral, about 80 to 90%. Similar to seminoma, composed of large vesicular cells having clear cytoplasm, well-defined cell boundaries, centrally placed regular nuclei, fibrous stroma infiltrated with lymphocyte, mature lymphocyte. And occasionally you see granuloma. A few produce elevated level of chorionic gonadotrophin, so HCG will be raised, not all, but some, and may have sensitive trophoblast. If they have sensitive trophoblast in this dysgerminoma, then giant cells on histological examination. They also express receptor tyrosine kinase, that is c-KIT in the tumor. These proteins are usually diagnostic marker. So if you do immunohistochemistry by c-KIT stain, it will be positive. May observe as a therapeutic agent also. So you can give c-KIT to those patients. Clinically, all dysgerminomas are malignant, but the degree of cellular atypia is variable. Only about 1/3 are aggressive. Thus, a unilateral tumor that has not gone through the capsule and are not spread have very excellent prognosis, means 96%. After simple salpingo-oophorectomy, the patient will be treated well. Those neoplasm are responsible to chemotherapy, and even those that have extended beyond the ovary can have often be cured. So now, when we were medical students, we usually used to think that if suppose somebody has cancer, means that patient is gone. But surprisingly, they have so much advanced chemotherapeutic agent that I have seen. For example, a patient I have seen with that much big abdomen, and she was given chemotherapy, and she recovered like this thing. And after chemotherapy, the surgeon opens the abdomen and take out the ovaries. So it shrinks like in a week time. And next time when I saw the patient was roaming around. So lucky that now the chemotherapeutic agent are really drastically changing the whole scenario. Overall survival rate is 80%. So very good. This is how it looks like. So mostly they are solid tumors with area of necrosis, variegated. And if you see under microscope, rounded nuclei, clear cytoplasm, and in between, you have septa like this one. This one. And in this septa, you see a mature lymphocyte. These are mature lymphocytes. This is another septa. You can see mature lymphocytes, right? And if you stay with PAS, they will be strongly positive. And if you stay with immunohistochemistry for c-KIT, it will be also positive for that. Endodermal sinus tumor or yolk sac tumor? Yes. Yes. So this is actually, these cells are arranged side by side. So they have clear boundaries. The nuclei are round, right? And some of the nuclei show atypia. And in between, there are stroma, septa, like this one. This is one septa, this is another septa. And in this septa, you see lymphocytes. These are lymphocytes, right? So it is commonly seen in seminoma as well as dysgerminoma. If you show me this slide without telling me this is ovary, I may say that this is seminoma. It's so alike. Indolable sinus tumor, as the name says, it's a rare tumor, but it's the second most common tumor, malignant tumor of the germ cell origin. Most patients are young children, young women presenting with the abdominal pain and rapid development of the the pelvic mass, derived from the differentiation of malignant germ cells, also from the extra-embryonic yolk sac lineage. The tumor is rich in alpha-fetoprotein and alpha-1 antitrypsin. So you may have both of the things in the tumor. And alpha-fetoprotein is a marker. For example, now I have a tumor of yolk sac, and I wanted to confirm whether it's yolk sac or not. I do immunohistochemistry for alpha-fetoprotein, and that will be positive for that. A characteristic histological feature is a glomerulus-like structure composed of central blood vessel enveloped by germ cells within the space lined by germ cells that is called Schuller dual bodies, and conspicuous intracellular or extracellular hyaline droplets are present in this tumor. Some of these stain with alpha-fetoprotein by immunoperoxidase. The tumor usually appears to involve a single ovary, but more rapidly and aggressively. These tumors were also almost uniformly fatal within 2 years. This is really a fatal tumor. Diagnosed by combination of chemotherapy has improved the outcome. So, as I said, nowadays chemotherapy is so good that they have drastically changed the prognostic features. So, this is a block picture. You cut it. You have solid areas, you have cystic areas. It has a blaze-like configuration microscopically, and you can see, if you see it carefully, these are droplets of alpha-fetoproteins, right? And this is Schiller dual body, this one, glomeruli structure with the central blood vessel surrounded by this germ cells. This is a diagnostic feature of yolk sac tumor. Clear? So you have to, if I put picture, I will never put this one. I will put this one as a yolk sac tumor. Clear? Choriocarcinoma is a very aggressive tumor, example of extraembryonic differentiation of malignant germ cells, and are histologically identical to those or common presented. You know that choriocarcinoma is also seen in the placental tumor, but these are more aggressive. These choriocarcinoma in the ovary are more aggressive than the trophoblastic one. The ovarian primaries are aggressive tumor that generally have metastasized widely through the blood vessel to the lung, bone, and other viscera at the time of diagnosis. Very aggressive. Although the ovary is not that much bigger in size, as you see in mucinous adenocarcinoma. Ovary will be smaller in size, but the tumor has left the ovary and metastasized to different area. Like all choriocarcinoma, they elaborate high level of chorionic gonadotrophin, HCG, which is sometimes helped in the establishment of the diagnosis and detecting recurrence. For example, if the HCG is more than 2000 or even 5000, and after operation, the HCG tremendously come down to 0. But if it is still high, means there are some areas where a metastatic lesion is still there. Okay, so this is a very diagnostic test for that. In contrast to choriocarcinoma arising in placental tissue, those arising in the ovary are generally unresponsive of chemotherapy. So chemotherapy is not that much useful in ovarian choriocarcinoma, and they are usually fatal. So this is how it looks like. So you see, this all area is necrosis. This is all necrosis. Only a few viable cells. They are so vastly multiplying that, only a few cells are identified, rest of them is necrosed because the blood supply of this area is not keeping up with the proliferation of the cells. I have seen one choriocarcinoma during my clinical practice. Uh, I received a gastric biopsy, and while looking at the gastric biopsy, I saw choriocarcinoma, and it was a male patient. So I asked the surgeon, I called him, and I asked him to see his testis. And he went to the patient and saw the testis. The testis was little bit increased in size, and he took the one of the testis which was involved, and he sent back to me, and it was a choriocarcinoma. So choriocarcinoma is very fast growing tumor. Okay, then other germ cells. So it is usually in a combination. Embryonal carcinoma, another highly malignant tumor of primitive embryonal type, histologically similar to that in the testis. Polyembryoma, again another malignant tumor, so-called embroid bodies are seen in that one. And the number three is mixed tumor, as I said, combination of dysgerminoma teratoma, dysgerminoma endodermal sinus tumor, or dysgerminoma choriocarcinoma teratoma. So it's a mixture of two tumors. Sex cord stromal tumor. So sex cord derived from the ovarian stroma. Two important tumors. One is granulosa theca cell tumor, which secretes estrogen, and the other one is sartolinidex, which secretes androgen, so masculinization. So usually in masculinization, the female shows the same features of hirsutism there. Granulosa cell tumor, they may be composed of almost entirely of granulosa cells or a mixture of granulosa or theca cells. So in combination of these two. Collectively, this neoplasm accounts for 5% of all ovarian tumors, although they may be discovered at any age, but usually they are seen in the post-menopausal woman. So usually unilateral, vary in microscopic foci of large, solid and cystic encapsulated masses. Hormonally active, have a yellow coloration. So you cut it, you see a yellow coloration cut surface due to the intracellular lipid levels. A small cuboidal or polygonal cells may grow in anastomosic sheets and cords or strands, and these cells are looking like a coffee bean appearance. In occasional cases, small distinctive gland-like structure filled with the eosinophilic material recall immature follicle, and these are called Egner body, which is a diagnostic feature of granulosa cell tumor. We have yolk sac tumor, and that is called Schiller-Duval body. Here it is called Egner body. So when you see, you will see the difference. The thecoma component consists of cluster of sheets of cuboidal to polygonal cells. Now, the granulosa cell tumor has two reasons of importance. One is there is potential to elaborate estrogen, and number two, hazards of malignancy. So majority of granulosa cell, they end up with malignancy. Functionally active tumor in young girls, that is a juvenile one. And remember the classification I have mentioned about the dysfunction uterine bleeding. So those female who are girls who have this dysgerminoma, they can have precocious sexual development and in a pre-pubertal girl. It is because of this tumor. In adult women, they may be associated with endometrial hyperplasia because of the estrogen, cystic disease of the breast, and about 10 to 15% of women eventually develop endometrial carcinoma. So, it affects breast as well as endometrium. All granulosa cell tumor are potentially malignant. All. You will not think of a benign one. It is difficult to predict the biological behavior by histology. The cell doesn't look like malignant, but they are. The estimates of malignance recurrence extension ranging from 5 to 25%. So this is how it looks like. Again, cut surface show solid areas in which some of the cystic areas are there. They are usually yellowish in color because of the hormone secretion, and they have variegated appearance. Now, if you see here, this is called external body. And in center, it's eosinophilic area and surrounded by these cells. And if you see it carefully, they look like a coffee bean appearance of the cells, coffee bean, right? Or these are called, this is a diagnostic histological feature of this Renzo cell. Now, thecoma, fibroma, and fibrothecomas arising from ovarian stroma composed of either fibroblast, fibromas, plump cells, droplets, thecoma, or a combination of both. Many tumors contain mixture of these tumors and termed as fibrothecoma. Pure thecomas are rare, but tumor in which these cells predominate may be hormonally active. Fibromas of the ovaries are unilateral, about 90% of the cases, and are usually solid, spherical, slightly lobulated, encapsulated, hard, gray-white masses covered with glistening, intact ovarian serosa. On histological examination, they are composed of well-differentiated fibroblast and scant interspersed collagenous connective tissue, focal area of theca differentiation. So it is really difficult when you see under microscope to differentiate it is theca cell or this is fibroma cell. So this is how it looks like. It is very hard because it's mostly of matrix tissue, white in color, solid, hard. And if you see under microscope, these are spindle-shaped cells, and some of them have thecoma cells, for example, this one, this one, this one. So it is really very much hard to differentiate between fibroma and thecoma. Now, sartorilytics or endoblastoma, as you know, that these cells, these tumors secretes androgens. They commonly produce masculinization and least or at least defeminization, but a few have estrogenic effect. They occur in a woman of all ages, although the peak incidence in a second and third decade of life. The tumor are unilateral and may resemble granulosa theca cell neoplasm. The incidence of recurrence or metastasis in sartorilytic cell is less than 5%. The cut surface is usually solid and vary in gray to golden brown. This is a typical of sartorilytic cell, golden brown color of these cells. Histological examination is of the well-differentiated tumor show tubules. So now well-differentiated, intermediate, and poorly differentiated. You see or differentiate by looking at the tubule formation. If you see more of the tubules, then it is well differentiated. If you see some of the tubules and some of the solid areas, then you call it intermediate. And if it is spinduloid cells, then it is poorly differentiated. So this is what it is all written here. Lytic cell may be absent. Heterologous elements such as mucinous gland, bone, cartilage may also be present in some of the tumors. This neoplasm may block normal female sexual development in children and may cause defeminization of the woman manifested by atrophy of the breast, amenorrhea, sterility, and loss of hair. The syndrome progress to striking volatilization, mean hirsutism, associated with male distribution of hair, atrophy of the clitoris, and wise change in those females who had this tumor. So this is how it looks like. So this is golden brown in color, right? This is area of necrosis, variegated appearance, solid structure. And when you see under microscope, now in this you can see majority of the tubular structure. So this is well differentiated, right? Because more than 90% are tubular structure. For example, this is half tubule. So if it is intermediate, so you see most of the tubule like this one. But here it is mostly full tubule. So this is well differentiated one. And in poorly differentiated, you see spinduloid cells. You will not see a single tubular structure like this one. Okay. And you can also identify lytic cells in between here. This pinkish color, these are lytic cells. So this is not only lytic cell. In between this structure, you have lytic cells. Now, finally, lastly, metastatic tumor. Most common metastatic tumor of the ovary are derived from tumor of the Mullerian origin, that is from uterus, fallopian tube, contralateral ovary or pelvic peritoneum. But the most striking extramullarian tumor metastasis of the ovary are carcinoma of the breast or GI, in especially colon, stomach, biliary tract, and pancreas. Now, they also include in this group are the rare cases of pseudomyxoma peritoni, derived from the appendiceal tumor. A classic example is the Krukenberg, which comes from GI, or especially stomach. By bilateral metastasis composed of mucin producing signet ring individual cells of the gastric organ. So this is how it looks like. So these are the ovaries, right? And this is the low power view, little bit high, and this is the highest one. So in low power, you see a pool of mucin in between, and if you see closely, there are bunch of individual cells. On high power, you can see these signet ring. Why we call it signet ring? If you see my ring, so this is nucleus, and this is cytoplasm, and it is the nucleus is pushed because of the mucin in the cell. So if you see and if you recognize, the signet ring is just like this one. So this is nucleus. This is all full of mucin, and the mucin has pushed the nucleus at one side. So it looks like a signet ring, right? So this is a basic peculiar diagnostic feature of metastatic tumor of the ovary. Clear? So this was all about both of the ovarian tumor. Any question? So we have another appendix of this what you call lecture. So please have that one again. Yeah.